Hit the subscribe button or visit us at auau.auanet.org.
Ahead now and move into our last session. I'd like to reintroduce Dr. Lang. He'll be addressing some of the issues regarding chemotherapy. We talked a little bit about treatment sequencing, and there were a number of questions regarding that, as well as future directions. I'd encourage everybody to plug in questions into the chat, and we can address them there or in the small group session. So Dr. Lang, you have control of your slides.
Very much. Thank you. Thanks, Dave. And thanks to everyone. The organizers have really done a phenomenal job on such short notice. And thanks to the audience. This has really been a lot of fun. The breakout sessions have really been enjoyable. And this is obviously the heart of what I do in my clinical practice, is understanding how we combine or sequence the many therapeutic options that we have for patients who have metastatic castration-resistant prostate cancer. Here are my disclosures. So when we think about how to consider sequence agents for patients with metastatic prostate cancer, generally speaking, we can combine, or I think this was a very illustrative table in terms of thinking about local therapy all the way through metastatic castration-resistant prostate cancer, mildly symptomatic, symptomatic, and those post-chemotherapy. And as you can see, there's a lot of overlap here in terms of when you could or when you might consider some of these different agents in the CRPC setting. Now, we had previously talked about Sipuleucel-T in terms of the most important points for when to use that agent. Again, generally speaking, it's for patients who are asymptomatic or really asymptomatic with a low PSA are the best patients for that class of therapies. Very important to counsel our patients as well on the expectations for that agent in terms of really not expecting to see a PSA or clinical response or radiographic response, with the expectation that they will then need to move on to their next line therapy really quite quickly after completing that course of infusions. But otherwise, CYP-T is a very well-tolerated therapy. I've had very few of any side effects beyond some mild fevers or chills that are really patients recover from quite quickly. One of the other important points we spoke about in one of the breakout sessions is patients who had the most benefit, generally speaking, were the patients who had the lowest PSA. So for patients, when we look at this post hoc analysis, the patients who had a PSA less than 22 seem to derive the greatest benefit in terms of differences in overall survival. And it's likely even patients lower than that with PSA less than 5. But all of these really, I think, speaking to patients with a low disease burden that is not causing any symptoms are the patients who will most likely benefit from CYP-T. In terms of Abiraterone and important considerations, generally speaking, patients with severe or refractory hypertension or other heart disease may not be good patients for Abiraterone. Generally speaking, that's a very challenging clinical situation for nearly any systemic therapy in prostate cancer, and really something where those patients should be seeing a great cardiologist to help optimize those different factors. Certainly would make an impact in terms of tolerability of Abiraterone, but also important for subsequent therapies. Other patients who have more complex medical histories, whether that's hepatic dysfunction, uncontrolled diabetes due to the potential toxicities or side effects from prednisone, or active infections, or other patients that may not benefit. Again, this is where, as a medical oncologist, I really rely on my internal medicine colleagues to help manage patients who have multiple complex medical conditions. In terms of enzalutamide, I think we heard before in terms of things that should be considered. Patients with a prior history of seizures on seizure medications really should have that discussion. I will say that was an extremely small number of patients in those clinical trials that did have a seizure, though those agents, it is a black box warning for the FDA. Other history of CNS issues, whether that's dementia, falls, fatigue, or advanced age. Again, enzalutamide, the most common side effect is fatigue. CNS toxicity is a real factor. So it's important to have that discussion with our patients before starting these therapies. One, so they can prepare themselves, but two, so that way, if there are changes, we can identify them early and we can lead to a plan for dose reductions as well, again, with the goal of tolerability. But when we're proactive, that can really be effective. Now, what about questions of sequencing? I think this is something where, traditionally we've thought, well, these are two oral therapies that relative to chemotherapy are much better tolerated. So why wouldn't we want to focus on the better tolerated therapy? So this was a randomized phase 2 trial that was published in Lancet Oncology in 2019. I've referenced it a couple of times. And essentially what they did in this trial is that patients with metastatic castration-resistant prostate cancer being considered for their first-line androgen receptor inhibitor were randomized to receive either abiraterone or enzalutamide. At the time of progression, patients crossed over to the alternate ARS signaling inhibitor. And what they found was that for patients who went from abiraterone to enzalutamide, that the PSA response rates, as shown here in group B, was exceptionally low, as was time on therapy. Now, the patients who were on enzalutamide and switched to that's the patients who went from enzalutamide to abiraterone. The patients who were on abiraterone and switched to enzalutamide had very low response rates. However, when we look at those different options of sequencing abiraterone versus enza versus abi, there was not a statistically meaningful difference in median overall survival. So a very interesting study, I think, to read that gives us some suggestion that these therapies are effective, especially in the first line setting. But it's really important to choose which one would be your preference in terms of the one to start. Because of the low response rates for patients going from enzalutamide to abiraterone, that might suggest that abi would be more effective. But also, again, this is where toxicity, whether that's financial toxicity, other clinical parameters, are really important, I think, when we make this decision. Other things to consider from a treatment sequence perspective of what about patients with a more aggressive disease, whether that's the presence of visceral metastases such as liver or lung metastases, patients who have a very short duration of benefit from androgen deprivation therapy. Those are patients that we may be considering or more focused on chemotherapies. This is also where biopsies really come into play as well. If we see any evidence of a neuroendocrine differentiation or more aggressive features of this prostate cancer, especially on genetic testing, and we'll talk a little bit about that later, those are other things that can help guide that decision-making process. Again, with the idea that we have many different options available to us. Very quickly, this is something that is coming more to the fore in terms of how do we manage or understand the risks of CNS toxicities from these androgen receptor inhibitors. So when we look at abiraterone and enzalutamide, this was in a supplement from ASCO. This was back in 2016. There was some suggestion that there was a change in cognitive impairment from baseline to 12 weeks or in depression that was more common in enzalutamide. Uncommon in abiraterone, though not impossible. We didn't do a great job in terms of assessing these parameters in the original phase 3 clinical trials with these agents. But again, this really just speaks to the importance of having this discussion with our patients before starting, so that way they, and oftentimes the spouses or families of my patients, they're the ones who clue me in, because we do have options in terms of intervention, whether that's dose reduction or other supportive care, such as antidepressants, which also have been shown to improve quality of life for men with prostate cancer. All right, and I'm going to skip to the next slide. So this is actually, I think, just another summary slide of multiple studies that build off of what I discussed with the Koloff study. So I'm going to go ahead and move ahead. But just again, that there are multiple studies, as Dr. K also mentioned, that support this, that the issue of going directly from abi to enza or enza to abi, that we should have very low expectations for clinical benefit, in which case that's where we should really consider alternate agents. In terms of Alcimca, this is a slide just to highlight that the clinical benefit in terms of survival was present for patients, whether it was pre-chemotherapy or post-chemotherapy. So it is something for us to keep in mind, though we'll talk a little bit more about some qualifications with the VISION trial and PSMA lutetium in a little while. But again, something that should be considered. One other aspect of this that we've talked about with regards to toxicity from Alcimca or from radium-223 that was found on the Alcimca trial was the risk of impacts on myelosuppression. So whether that risk of neutropenia or decreased platelets, that those are real factors, including decreased hemoglobin. It does seem that the use of docetaxel before is associated, as well as patients who have a high burden of bone metastases. So again, other things to consider, again, of when's the right time to use radium-223. In terms of other options, when we think about the efficacy of docetaxel, so very quickly, we do know that docetaxel improves survival for patients with metastatic castration-resistant prostate cancer. Now, these are, in some ways, historic studies published in 2004 and showing that the use of docetaxel on a Q3-week basis improves survival. However, this was before we had many of our other novel hormonal agents approved. So at the same time, this is something absolutely in our armamentarium in terms of ways to attack prostate cancer. But who would we recommend this for? Now, we've talked about the tolerability of AR signaling inhibitors and why we often prefer those. In terms of the best patient for docetaxel, certainly for patients who have symptomatic disease. We know that this improves quality of life in terms of as well as survival. Patients who have signs of a more differentiated, again, concerns for that neuroendocrine differentiation. So the presence of visceral metastases, very rapid PSA doubling times or radiographic progression. And as mentioned, using after your Abiraterone or Enzalutamide and that AR inhibitor. And again, thinking about docetaxel in the metastatic hormone-sensitive setting as well. Now, I briefly wanted to touch base on Cabazitaxel. Now, Cabazitaxel is a semi-synthetic taxane. And as you can see here, that there is very, very little difference with docetaxel at the molecular level or at the structure of the drug itself. Now, Cabazitaxel in preclinical models was shown to be efficacious in terms of treating, having an anti-cancer effect in cell lines that were resistant to docetaxel. So that led to phase 3 trial, the TROPIC trial. At the time, again, this was back in 2010, where it compared Cabazitaxel against mitoxantrone, so in patients who had progressed on docetaxel chemotherapy. And it was shown to improve survival for that for patients in that clinical situation. One of the really important caveats of this trial was the risk of febrile neutropenia was very high. And unfortunately, in this trial, there was also a toxic death rate approaching 5%. Importantly, these were patients who had not received G-CSF prophylaxis. And that's really one of the mainstays for Cabazitaxel, regardless of age, certainly for patients over the age of 65, but really for Cabazitaxel, regardless of age, all these patients should receive G-CSF because of the high risk of neutropenia and infectious neutropenia with this agent. In terms of dosing of this agent, it was originally approved in the TROPIC trial at 25 milligrams per meter squared. And since then, there was another clinical trial that asked, well, is 25 potentially too high? And what they found was essentially patients, this was a randomized phase 3 trial of 25 versus 20 milligrams per meter squared, which anecdotally was also at the maximally tolerated dose of Cabazitaxel in the phase 1 trial was 20 milligrams per meter squared. So essentially they went back and did another phase 3 trial, and we can talk about this in the breakout sessions if you'd like, but the short is that there was no difference in terms of overall survival between 20 and 25. So 20 milligrams per meter squared is the preferred dosing strategy for Cabazitaxel. Similarly, again, what kind of adverse event should we expect? Again, really be prepared for neutropenia. And what this slide illustrates is that the incidence of febrile neutropenia was significantly lower at 20 milligrams per meter squared compared to 25 in the Procelica trial. At the same time, again, we're still giving G-CSF prophylaxis for all these patients. Now, I want to spend some time talking about sequencing. And we've talked about some of the pros and cons of the other therapies we reviewed. But here was a very important trial published in 2019 in the New England Journal of Medicine, asking for patients who had progressed on one AR signaling inhibitor, Abiraterone or Enzalutamide, what's the next best therapy? Now, we've talked about the limited response rates of going from Abi to Enza or Enza to Abi, but is there something else that we should be using from a therapeutics perspective? So the CARD trial enrolled patients with very high-risk prostate cancer. So it's worth looking at that eligibility. It wasn't all patients, it was patients with very high-risk disease. And they were randomized if they'd had Abi to go to Enza or to get docetaxel. If patients had had enzalutamide, they were randomized to get, to get Cabazitaxel or Abiraterone. So that was the switch there. Importantly, what they found in the CARD trial was that for patients who had progressed on one prior AR inhibitor, Cabazitaxel was far superior than getting a second AR signaling inhibitor, with a difference in terms of progression-free survival of 8 months versus 3.7 months. And as you can see in the Kaplan-Meier curves, patients who got that second AR inhibitor, nearly 50% of patients progressed radiographically at the time, by 3 months, their first restaging scans. I will point out that there is still a small percentage of patients that do receive benefit from a second AR signaling inhibitor. And this is, I think, where some of the molecular information we'll talk about later is giving us a better understanding of who those patients are that may benefit. What you're seeing here is the improvement in overall survival. So 13.6 versus 11 months. Now, again, noting that the control arm here, that survival is still less than a year. So again, we're talking about very high risk patient population with a very aggressive disease. And this is just mandating what you're seeing here on the eligibility criteria. Now, I've kind of alluded to this a few different times of the kind of the questions I ask myself when my patients come in and they progressed on Abiraterone or enzalutamide. And I ask myself, is this still an adenocarcinoma? Is it still the original prostate cancer that we've been fighting for, hopefully many years? So these are some of the considerations that can help you with that decision. The first is there any evidence of visceral metastases on conventional imaging modalities? So that includes CT, chest, abdomen, pelvis, as well as the nuclear medicine bone scan. Very bulky lymph nodes, a low PSA in the setting of a high volume disease. So again, discordance between the serum PSA and what we see radiographically. Lytic rather than blastic bone metastases also is a poor prognostic factor. And then this comes back to the idea and the importance of getting a biopsy from a metastatic site for somatic testing. You'll hear from the folks who do genetic testing that a soft tissue lesion, it's easier to get DNA out of that lesion. Fortunately, there have been a number of advances in terms of performing bone biopsies as well. Here at the University of Wisconsin, we have better technology in terms of CT guidance, as well as the needles that are used to acquire those bone biopsies. Our pathologists have also updated their practice to avoid decalcification, but still fixing that biopsy sample. So that way it's much easier to get good DNA extraction. We're at the point now where our success rate here at UW, and I think a number of academic centers, is close to 90%. And I've even had some radiologists tell me they actually prefer bone biopsies, especially compared to liver biopsies with bleeding risk, lung biopsies for patients with lung cancer where there's a risk of pneumothorax. For most bone biopsies, my patients tell me they kind of had a sore hip, for example, if they had an iliac biopsy, and within a couple of days after some ibuprofen, they're back to normal. Now, one of the things that we're most concerned about is that we've had a transition from an adenocarcinoma to a neuroendocrine, or even worse, a small cell prostate cancer. Now, for patients who initially present with neuroendocrine or small cell prostate cancers, this is quite rare, less than 1% of all diagnoses. It's commonly associated with a disease that's very resistant to hormone therapies, low PSAs, generally speaking, and then also visceral metastases as well. We can do IHC, a tissue staining for synaptophysin or chromogranin A, but I think more importantly, as I keep mentioning, we want to do molecular testing. So when we do genetic testing, what we can find are DNA repair alterations that are common in metastatic prostate cancer, less common in neuroendocrine or small cell cancers. So what can we look for on these genetic tests? So I'm going to walk you through a couple slides in terms of what are we looking for and how do we interpret this? And I'm also kind of rehashing a little bit of what was described by Dr. Gamella in terms of, and I know this is very hard to read, but at the top we can see androgen receptor mutations or genomic alterations are very common. Alterations in DDR genes such as BRCA2, somewhere around the order of 15 to 20%, depending on the series that we look at. And also, again, we've had the discussion already in terms of Dr. Pritchard's study, in terms of germline alterations in some of these genes and how that's used for selection for Olaparib and Rucaparib, again, depending on which prior therapies this patient has had. I'm not going to spend a lot of time. I think this has already been discussed exceptionally well by Dr. K in terms of how we target BRCA mutant prostate cancers. and how we know that Olaparib is, why it's FDA approved, especially for patients that have these somatic alterations. I will say the patients who get the greatest and deepest or prolonged responses are those that have a germline alteration as well. Again, highlighting the importance of somatic and germline testing for all patients with metastatic prostate cancer. I will say that for somatic testing, that's something that for any of my patients with metastatic disease, that can be done at any time, and you don't need to wait to get somatic testing done, or I'm sorry, to get germline testing done. We've already reviewed the PROfound trial in terms of where we saw, especially for patients with BRCA1, BRCA2 mutant prostate cancers, a significant improvement in terms of rPFS as well as overall survival. Again, this was for patients who had had either an AR signaling inhibitor or an AR signaling inhibitor plus chemotherapy, and followed by chemotherapy. There are other less common genomic mutations. So when we think about PP2R2A, CHEK2, RAD51B, so those are also in that family of DDR genes. However, the majority of benefit seems to be for patients who have BRCA mutant prostate cancer. So we're all anxiously awaiting the results of the other trials that were mentioned by Dr. K, combining Olaparib with Abiraterone or Abiraterone with Niraparib, and some of the other agents, new PARP inhibitors in development, to see how effective those are in an unselected patient population. This was a slide in a series that was done at the University of Washington, so the other UW, looking at their rapid autopsy cohort and looking for eligibility for pembrolizumab. So that's in microsatellite unstable prostate cancer, so MSI high. And those MSI high cancers can be found anywhere, again, depending on the series, from 2 to 11% of patients. I will say this is, generally speaking, is a very rare situation to find. Again, highlights the importance, because if you do find it, this is a great option in terms of an overall well-tolerated therapy. But otherwise, pembrolizumab for patients with prostate cancers that do not harbor these mutations, again, the benefit is really non-existent. I wanted to briefly talk about PSMA lutetium. So this is a really fascinating therapeutic concept and builds off of what we discussed earlier in terms of PSMA or Pylarify for an imaging agent, for a PET imaging agent. So appropriately, a number of groups have asked, well, what if we take those small molecules, recognize PSMA, and conjugate them to a therapeutic? So in this case, lutetium-177. And what you're seeing here, so this was in a series of patients who had PSMA PET positive disease. And what you're seeing here is an example of one patient who had widespread metastatic disease in bone and lymph nodes, who received a type of a PSMA lutetium conjugate and really had a dramatic response on PSMA scans and very common decreases in PSA as well in this small trial. So as PSMA lutetium has been developed, it's been explored in different prospective clinical trials, showing that we can see PSA response rates in different series up to 40 to 50% of patients. It is not without toxicity. And that's something else to highlight in terms of a grade 1 dry mouth in this series of 87% of patients. And actually, just to explain what that grading is, because I was not familiar with that because I don't see it with any other therapies. Grade 1 dry mouth means it's something that impacts quality of life and you may need to drink something at the time that you're eating. A grade 2 dry mouth is actually when you require something to drink, meaning that you do not produce enough saliva to eat and swallow food. So that's a really significant impact in terms of grade 2 dry mouth. Grade 3 dry mouth is actually required TPN, so IV nutrition. Very uncommon to see grade 3 toxicities, but especially for an adverse event that does not resolve, generally speaking, it's something that's very important to counsel our patients on. And that leads us to the VISION trial. So this was recently published in the New England Journal of Medicine. Generally speaking, in this session, we restrict ourselves to FDA-approved therapies. But I'm sure, like me, you're getting asked about PSMA lutetium by nearly all of your patients. So I thought we'd just talk about this very briefly. So this was a phase 3 open label trial in which patients who had had at least one AR pathway inhibitor and one taxane chemotherapy were then randomized to receive another AR inhibitor with or without PSMA lutetium. In terms of eligibility criteria, patients had to have a gallium PSMA PET scan performed. And those PET scans, all of the lesions that were identified had to be PSMA PET positive. Now, the caveat to this, and it's really worth reading the eligibility for that trial in the New England Journal of Medicine report, was that patients use it with conventional imaging if a lymph node had to be at least 2.5 centimeters to be considered a concerning lesion, and then it had to be PSMA PET positive. So what that means is that there were very possibly metastatic lesions that were PSMA negative that were not identified with that imaging modality. Again, very difficult to identify, but I think appropriate for eligibility for this trial. But again, it's a caveat that I think is important to keep in the back of our minds, especially when we look at the efficacy. So I'm going to skip this in terms of some of those eligibility and some of the challenges that they had initially in terms of enrollment to this trial that were ultimately sorted out. But talking about the efficacy, what they found with the PSMA lutetium in all randomized patients was that there was a 4-month improvement in rPFS. So 11.3 versus 15.3 months. It also improved overall survival, 14.6 versus 10.4 months in the rPFS analysis set, compared to that standard of care therapy. It was that OS benefit was observed across nearly all pre-specified subgroups, indicating that this is a therapy that does have therapeutic benefit for men with CRPC. Here's the primary endpoint in terms of rPFS, and not unexpectedly, patients getting an AR signaling inhibitor alone, about 50% of patients progressed by month 3. While in this, and let me correct myself from earlier, I'm sorry, the rPFS was 3.4 months versus 8.7 months, excuse me, with the addition of PSMA lutetium. So really an exciting advance. However, for many of us in the field, this was in some ways a little bit underwhelming. We were hoping for more, that if all patients who were enrolling had PSMA PET positive disease, we're hoping for more extended benefit. And that's leading to some new questions in terms of, were the eligibility criteria for PSMA PET positivity appropriate? And are we missing potentially PSMA PET negative cancers? Again, those potentially neuroendocrine cancers. And therefore, if they don't express the target, they won't respond to that particular therapy. Otherwise, it was a relatively well-tolerated therapy. Again, we talked a little bit about the AEs and what we have to be careful for. So just to very briefly summarize, we have multiple FDA-approved therapeutic options. Sequence is important. And the more we can get molecular information from biopsies to guide us and inform us, I think that's really going to help us tell our patients, which is the next and best therapy for you. The one thing that I just will keep in the back of our minds is that patients who have had radium-223 were not eligible or not enrolled to the PSMA lutetium trial, to the VISION trial. So that's something that's going to be a major point of discussion. So if you want to come back next year, we're really going to delve deeply into that, again, as we get more data and ask, how do we sequence these radiopharmaceuticals?